I'll just talk about the surgical technique and the principles of surgical technique in deep anterior lamellar keratoplasty, basically oriented towards how a beginner should be approaching this technique so that they are able to achieve it successfully in most of their cases. Due to paucity of time, I will not be running all my videos and just probably take you through two simple DALK surgeries so that you will not have much hesitation when you're beginning this surgery. I have no financial interest in any of the procedures or instruments shown throughout the course of this talk. Deep anterior lamellar keratoplasty is a technique by which we are entirely bearing the Descemet's membrane, and entire stroma is removed and replaced by the host corneal tissue. And this gives fantastic results in terms of the interface haze being minimal. And but later results, recent results are showing that maximal depth lamellar keratoplasty versus a complete Descemet's bearing lamellar keratoplasty in the long run will probably give you almost similar results. So when you're looking at training yourself or becoming or moving into becoming a deep anterior lamellar keratoplasty surgeon, the 4 important steps you'll have to look at very cautiously is that optimal training is always achieved by proper self-learning and supervised learning. There is no shortcut for that. You'll have to learn to identify the cases pre-operatively and decide which are the cases which are suitable by a big bubble DALK, which are the cases which need to be taken by tackled by a manual DALK procedures, which is very imperative in proper planning and surgical technique. There are certain intraoperative considerations which I'll talk about when I'm running the videos, and of course very important is the postoperative management as well. Due to lack of time, I'll just go on for the techniques only. I will not talk about the preoperative evaluations and the ASOCT scans required. So here you see a suction trephine being used to make a perpendicular cut to the desired depth. The anterior layer of the cornea has now been removed by a manual lamellar dissection. A big bubble is being achieved on the first attempt in this particular case. Don't be discouraged, you might not always land up with achieving big bubble technique on the first attempt. Once the big bubble has been achieved, then there is de-roofing of the big bubble technique done, and by a divide and conquer technique, the remaining of the stroma is removed to bear the Descemet's. The donor button is prepared as was shown in the previous 2 presentations, and this is placed on and sutured onto the host bed. Most of the times, the good thing about this procedure is you can use non-optical grade corneas to do deep anterior lamellar keratoplasty, and that really expands the utility of your tissues which are being offered by your eye bank. So important steps which you'll have to learn to master or look at carefully would be proper centration, as it is for any keratoplasty surgery. Trephination plays an important role so that your cut needs to be exactly perpendicular up to the desired depth. And this is not achieved, then removing the remaining layers of the stroma after achieving the big bubble can be a little difficult. And as beginners, you could land up having perforations when you're trying to remove the peripheral ledge. Anterior lamellar dissection is to be done before you place the bubble as a beginner. Do not do your anterior lamellar dissection after you place the bubble in the stroma. Especially if you're a slow surgeon, you're being very cautious, then you could lead on to precipitate a Uret-Zevelia syndrome because of the intraocular pressure or the eye being taut for a considerable period of time. Learning to achieve the big bubble correctly, which by and large is still a blind procedure. By feel, you know where your tip of the needle is and how you are bubbling. So the type of bubble you achieve, you should know that this is the kind of bubble you type 1 or the type 2, and you might probably need an additional procedure after you've achieved your big bubble if you've got a type 1 procedure done. The complete bearing of the Descemet's membrane is the secret of obtaining a successful surgery, and also knowing how you would not rupture your bubble. So before you do your bubble, always remember to do a paracentesis, which helps to decrease the intraocular pressure and gives enough space for your bubble when it's achieved to push the Descemet's into the anterior chamber. And of course, donor butter preparation and suturing and postoperative will be a routine for anything. Just a simple animation to show this is a type 1 bubble where the posterior most layer of the stroma, known as the Duas layer, has been left behind. A type 2 is the real Descemet's bearing bubble if you achieve, and your surgery is relatively easy. And you can have a mixed type of bubble as well. Various instrumentations have been described for achieving success in the surgeries. Again, another case of DALC in a keratoconus. So the initial trephinations has been completed. You see the central cone is quite thin and large, so a manual lamellar removal of the anterior layer is being done very carefully. Here you can see the bubble being achieved, and as the air is also traversing retrograde through the trabecular meshwork, has also gone into the anterior chamber. So something like a small bubble test or a double bubble test, which has also been described for DALC2, to know where exactly your bubble has been placed. The first bubble was not in the exact plane, so you see I've now achieved my big bubble and enlarged it further now. And this is when your eye is actually taught. And if you're a surgeon who's just getting into it, please don't attempt a lamellar dissection after you've achieved a big bubble, because you might be very slow and you would land up in a urethrozelia in such cases. So the bubble is still there, the eye is taut. We are just doing divide and conquer technique for the removing of sort of the middle stroma here, because I'm still not sure where exactly my bubble is. The de-roofing of the bubble, or the brave slash as it is called, I think that's the most important step, or the most difficult step, or the step at which you really are not sure whether you're in the right plane. So here, before doing I'm just trying to do the brave slash. Few other ways of doing this: you can mark the layer where you have achieved, and if you don't want to do in the center because you're scared, as done in this case, I've done a peripheral slash and filled it with viscoelastic, and you could see as the viscoelastic went in, the bubbles in the anterior chamber were moving peripherally, which shows your cleavage plane has been rightly achieved. And once you're sure and you have sort of, in this case, close to your space or filled your space with viscoelastic, you're comfortably going and removing the remaining roof of the big bubble chamber. And here is the remaining stroma is also being removed. You could see the bubbles in the chamber beneath the bare Descemet's membrane. And once this is achieved, then it's simple, and just placing back placing your host cornea, the donor button onto the host cornea and suturing into space. So important tips to repeat again is proper preoperative selection and deciding which technique works best for the case which you have done well and which you have chosen to do, and always aim to achieve a complete barring of the Descemet's membrane, and remember to do a paracentesis before you achieve the big bubble. And always remember that it might not be possible to achieve the big bubble in the first go only, and even after achieving the big bubble, depending upon the type of bubble you achieved, you might still have to do a manual procedures. And it again is a comfort level of the surgeon, whether you are doing a big bubble or manual technique, you could still achieve Descemet's barring, DALC procedures, and your post-operative results could be very good. I think for lack of time, I will not go into the remaining surgeries, as I think the complex scenarios will be covered by Rishi, and Revati will tell you about lamellar dissection techniques for DSEC as well. Welcome you all to our forthcoming DOS conference as well. Thank you for your patient hearing. I think if there are any questions, we can take it at the end of the session together.
Thank you, Dr. Vanathi. The next presentation is by Dr. Rishi. He is taking us to some other subject, that is posterior lamellar keratoplasty.
At the outset, I'd like to thank Dr. Panda and Dr. Vanathi for including me in this course. I've been part of this course for 2 years, and it's always very nice. Okay, so since the basics have been covered, I'll just talk about the advanced scenarios. So in addition to your routine cases of DALC, the advanced scenarios essentially include corneas that are too thin or are thin peripherally or throughout, like pellucid, keratoglobus, very advanced keratoconus. You have cases where there is scarring of the stroma which very close to the Descemet's membrane, so you can't really do your conventional big bubble technique in these kind of cases, and cases that have infectious pathologies which are involving most of the cornea. So these are all different scenarios where your classic surgical technique of big bubble as described in the previous will become difficult. Okay, so either the cornea is too thin or too ectatic, or the cone is too large. When you're assessing these cases preoperatively, it's important to understand the size and location of the pathology. See if there are any deep scars near the descemes membrane or any markers of an old hydrops which increase the chance of perforation during various dissection techniques. See the proximity of your pathology to the limbus and whether your dissection would go that peripheral, and see the severity of the thinning. And a useful tool for doing all these assessments is the OCT, which gives you a pachymetric map which gives you the overall extent of your disease. It also helps you understand the morphology of your deep stroma and your descemes membrane. If there are any irregularities like these, they indicate that there is something that has happened, like a hydrops or something, which may preclude a good big bubble. Also, it gives you an idea of, when you're looking at the corneal thickness, how much of it is the epithelium, how much is the stroma. So if you're going to plan to introduce a needle, you can decide which of the areas you want to avoid. So big bubble technique has been described. Essentially, you are injecting air in the deep stroma and it's finding its way through the deep stroma into the predescemes space anterior to the so-called Duas layer, and that helps to separate the stroma from this layer so that you can safely remove the stroma without damaging the inner layers. And most of the time it works very well if you get a good bubble, okay? But sometimes you don't get it, either because you've been too anterior in insertion of air, or there's something wrong with the cornea in which you're injecting the air. That's why the air is not able to find its way in the deeper space. So if you get it, it's really nice, but sometimes you do have problems. So if you do have problems, you can always do one of the manual techniques of deep lamellar keratoplasty. You can also do this primarily. I often prefer to do the manual techniques because in my hand that works very, very predictably and I get fairly good results. So this is the technique that I use. I create a peripheral groove along the trephination mark using a pair of normal universal corneal scissors. So just how you do dissection in general surgery, you use a scissor, kind of do a blunt dissection and then cut in the area which you've dissected. So you're essentially, whenever you're cutting, you're only cutting an area which has been pre-dissected. And to dissect, you're using a blunt instrument like the universal corneal scissor with the curve pointing upwards. So the chance of perforating during this is very, very low. And all your dissection is happening in the peripheral cornea along your groove. So you basically make a whole circle and then you go in a deeper plane like a spiral. And you keep doing this till at some point you encounter the glassy predescemes or the descemes, which looks something like this. It's shiny and you don't see too much of fibers on it. You expose about 2 or 3 clock hours and then you can just hold that central island of stromal tissue and just peel it off. So essentially in the central cornea, your dissection is only by stretch forces which are distributed over a larger surface area. So the chance of perforating is much, much lesser, especially if you've not had any deep scars which stick the stroma to your descemes or predescemes layer. So you can just grasp, you can give counter traction with another forceps at the limbus or at the trephination junction. And you see even areas where you have not dissected, you can just kind of pull it away. I have so many videos in which this just comes again and again consistently. It's very, very easy once you found the plane. And these little fibers that are left behind don't really matter either optically or visually. The visual results are as good as a big bubble talc. I can show you post-op results. So this is a case done by this similar technique, and you can see as early, you can see the air bubble. As early as the first day, the graft is very clear, as good as you would get in a penetrating keratoplasty. In keratoglobus, we've seen that the stroma is not really attached to the predescemes or descemes layer. And once you've gone into the plane, you can actually just peel it off like a LASIK flap. There's really no fibril attachments, and that's probably the reason why these stromal fibers are just sliding on each other and the whole cornea starts bulging. So I'll just show you in this next video. You can just kind of hold it and there's really nothing holding the stroma to the descemes, it just comes off. Femtodalc is something very useful. It's useful especially when your pathology is in the central cornea. So for example, this is a nipple cone, quite an advanced central cone, but the peripheral cornea is quite thick, as you can see. So you can easily remove it using a femtosecond laser, and the advantage is you can use these mushroom cuts. So you sacrifice more of the stroma and